Okay, good morning. Are we where we want to be, Jessica?
Yes.
Okay, and I don't see myself, but here we go. All right, I guess I'm having a little. Okay. Do we have anybody to let in?
Yes, we have.
Okay, now I can see. Now I can see everything. All right, let's get started. Good morning. I apologize for that delay. We had some technical issues. It is 10 a.m., a couple minutes past August 3rd, and this is the hearing to present the Nevada Drug Transparency Program and report for 2022. I'm Linda Fox. I'm the program manager. Jessica Gerhow is here. She's our management analyst, and she is assisting. As with all public hearings, there will be 2 opportunities for public comment. If there is enough interest, we will limit those to 3 minutes. It doesn't look like there's too many people here today, so we may not have to limit. The link to the report itself will be in the chat box, and then Jessica is also going to share on screen that report so we can look at the graphs and the tables together. And with that said, we will start with public comment. So is there anybody that would like to make a comment? And Jessica, I can't see that because my screen is shrink, so I'll have to have you look for comments. No commenters, Jessica?
I do not see any hands raised.
Okay, then I'm going to go ahead and get started. So first I wanted to go through the obligations of the stakeholders as well as the department regarding this program. So DHHS, or the Department of Health and Human Services, is required to compile a list of medications. So first we compile a list of essential diabetic drugs. And then in addition, a list of those diabetic drugs that had a significant price increase, as well as another list of any medication that costs over $40 per course of therapy and had a significant price increase. So the final versions of these lists were published March 26th. In addition, each year the department is required to produce a report regarding all the information submitted to the program and analyze that information. Our law now also includes a requirement to publicly present the report, as we are doing today. Manufacturers have the requirement to respond if their drugs appear on Nevada lists. So if their drug appears on the essential diabetic drug list, they're required to submit a report with data outlining drug production cost, profit, financial aid, and other drug-specific information and pricing data. For drugs that experience a recent significant price increase, manufacturers are required to submit a report that provides a justification for these price increases. PBMs, or pharmacy benefit managers, are required to submit reports regarding rebates negotiated with manufacturers for drugs on either the diabetic drug list or the over 40 drug list. Both. They have to report on both. This year, wholesalers began reporting for drugs on these lists. Wholesalers report information regarding WAC, or wholesale acquisition cost, volume shipped into the state, and details regarding rebates. Nonprofits also report, but they may either submit data or publish on their own website. Pharmaceutical sales reps are required, well, DHHS is required to maintain a registry of sales reps that market prescriptions in Nevada. We define that as if they have 5 or more days of activity in Nevada. These representatives are required to submit a list of healthcare providers and other individuals to whom they have provided drug samples and or any other compensation in the previous year. A reportable event is any exceeding $10 per individual or a total compensation exceeding $100 per event, again, during the previous calendar year. So Medicaid, we evaluate Medicaid to look at trends, Medicaid claims to look at trends as they apply to the posted drug lists. Medicaid Managed Care Organization and fee-for-service claims data for Nevada were obtained from the DHHS Office of Analytics. And although Medicaid only represents a segment of Nevadans and is not a complete picture, it gives us a point of reference. So Jessica, this would be table 1 I'm going to look at now. It shows us the average cost of a Medicaid claim over the past 5 years, a Nevada Medicaid claim. So in 2017, an average claim was around $85, just over $85. And you can see each year it went up a little bit. Oops. I lost my screen. To $109 in 2021. So in the past 5 years, that's a over 28% increase. You can also see the number of Medicaid prescriptions went up pretty significantly in those 5 years. And obviously the total spend went up as well. So I want to describe the lists in a little more detail. DHHS publishes 4 lists, and we just named them list number 1, 2, 3, and 4. List number 1 is intended for consumers. It's essential diabetic drugs, brand versus generic. No stakeholders report on that list. List number 2 is essential diabetic drugs. We get this information from First Data Bank. It has nothing to do with price. It is simply drugs that are used to treat diabetes. 1,029 drugs appeared on this list. The third list we make is those essential diabetic drugs that also had a significant price increase over the last 2 years. This is list number 3, and 151 drugs appeared on this list. For a drug to appear on this list and to have that significant price increase, the criteria is it must exceed the Consumer Price Index medical care component over the last 2 years. So specifically exceed the previous year or double the last 2 years. So for this report, those numbers were 2.2% for 1 year and 8% for 2 years. The CPI is designated to measure inflation over time and is published by the U.S. Department of Labor. This measures the average percentage change over time in the prices paid by consumers for medical care and goods. These values act as a benchmark with which diabetic drug increases are compared to identify the drugs that had a significant price increase. Our final list, list number 4, is any medication that exceeds $40 for a course of therapy and had a significant price increase. Significant price increase was defined differently here, and that was simply 10% for 1 year, 10% increase for 1 year, or 20% in the previous 2 years, and 178 medications appeared on this list. So I want to go back to Medicaid a little bit and how it interacts with those lists I just described. So I had mentioned a Medicaid claim on average was just over $109 in 2021. If you looked at a claim that was an essential diabetic med, that average was $263. And sorry, Jessica, I didn't mention this was table 5. Essential diabetic drug, about just over 263. An essential diabetic drug with an increase, that would be from list number 3. The average cost for a claim was $753. And a medication on list number 4, the over 40 list, the average cost was $948. 4.6% of the medications billed to Medicaid were essential diabetic medications. These medications cost over $89 million, so they were about 11% of the spend. So this means the percent spent exceeds the percent of prescriptions, as we have seen each year. Diabetic medications that had a significant price increase comprised just 0.86% of the total Medicaid prescriptions, but 5.9% of the total Medicaid spend. So again, disproportionate. The average diabetic claim was $263 for 21, an increase from $231 in 2020. and $238 in 2019. Medications on the over 40 list made up a small percentage of Medicaid prescription claims. And again, the spend. So the spend itself was also small, but it was disproportionate. So the medications comprised less than 1% of the total prescriptions billed to Medicaid, but the total cost was over $4 million. And that cost per prescription was disproportionately high at $948. So next I wanted to look at the over 40 claims by what condition they treat. This is broken down by the number of drugs that showed up on the list. Jessica, this is figure 1. So this is broken down by the number of drugs, not the number of claims in this first figure. The second figure, figure 2, does look at number of claims. So the most prevalent group was medication to either treat opiate dependence or was an opiate. That's at 20, gosh, I can't even read I think 25%, followed closely by mental health, which was 17%. And then the next figure, figure 2, does look down at a breakdown by claim. And then opiates were, I think that's 43%. It's actually so small here. And again, followed by mental health. So drug manufacturer financial assistance and PBM rebates. Manufacturers reported financial assistance provided to consumers and rebates that were provided to PBMs. Some PBMs pass all these rebates on to insurers or consumers, while others retain a portion of the rebates. Most of the essential diabetic drugs are generic and typically do not provide aid that I just mentioned, rebates, patient assistance, or coupons. We're now looking at figure 3, and the total amount of financial assistance provided through patient prescription assistance programs reported was 1.7 million. The value of the aggregate rebates that manufacturers provided to PBMs for Nevada drug sales was 245 million. And I'm sorry, I meant to say billion. That was 1.7 billion, not million. My apologies. So if you look at figure 3, this is aggregated information from all the reports we received, and you can see the biggest expense listed by manufacturers was production cost, followed by administrative cost, and third was profit. So essential diabetic drug manufacturer price increase justifications. Price increases were reported in 2 places. The first was all drugs on the essential diabetic drug list had to explain any increase in the last 5 years, even if it was not considered a substantial increase. And these responses are depicted in figure 4. To assist in analysis, these were standardized into major categories and quantified. Most drugs had more than one justification. The details of the breakdown of each, like drug compliance, research and development, like what might fall within those categories, are better explained in Appendix 2. So figure 4 is justifications for any increase, and figure 5 is justifications for significant price increases. So that is a little confusing because there were 2 places for it to be reported. So the manufacturers that submitted a price increase justification where there was a substantial increase had to explain those increases only over the last 2 years and not the last 5 years. Some respondents, instead of reporting a reason, instead reported a philosophy regarding how drugs should be priced. And I kind of alluded to, but manufacturers responded to increases and their responses were weighted. So weighting allows for a data set to be corrected so that the results are more accurate, representing the information being studied. As an example, a manufacturer responding with 1 NDC would be counted once, and a manufacturer with 10 NDCs would be counted 10 times. For the essential diabetic drug report, there were 13 manufacturer responses with increases. For the significant price increase report, there were 33 manufacturer responses. So in figure 4, where they responded to any increase, research and development was the predominant answer, and in figure 5, where they were just responding to significant price increases, marketplace dynamics, followed by manufacturing costs, that was the dominant answer. So pharmacy benefit manager reporting. PBMs reported rebates negotiated with drug manufacturers for prescription drugs included on Nevada lists. PBMs reported the rebates they retained, as well as the rebates that were negotiated for purchases of drugs for use by recipients of Medicaid, recipients of Medicare, persons covered by third-party government entities that are not Medicaid or Medicare, persons covered by commercial insurance, and then any other. Total reported rebates that PBMs negotiated with manufacturers for essential drugs were greater than 88 million. And Jessica, this is table 6 I'm referring to. The total reported rebates are broken down into 5 categories that I just listed. Some reports from PBMs could not be included in this final report as the data was not reported as requested, and it would have distorted an aggregated result. So what is displayed in table 6 is a compilation of the reports submitted that had the data we requested. This year, PBMs were required to break down by NDC, and we think that may have caused some of the difficulty. In fact, some responders did indicate that was the problem. Some of the other issues we saw with PBM reporting, some reported no data at all because they utilized a third party to negotiate rebates. Some reported on NDCs, on all NDCs rather than the NDCs on the Nevada lists. So the numbers were inflated. Some reported on NDCs on part of the report, on all NDCs on part of the report, and then other parts of the report, just the requested NDCs. And in some cases, the data did not correspond logically. For instance, the indicated more was retained than was negotiated, or the individual groups negotiated exceeded the total. So what we have done is edited the templates so the next go around of reporting should be correct. We might need some further editing, but we are addressing that so that we won't have the same issues we've had in previous years. And looking at table 6, if you look at the bottom row, you can see 36 million out of 88 million was retained by PBMs, so just over 40%. Regarding pharmaceutical representative reporting, a total of 266,144 events were reported for compensation and sample distribution. This included 1,174 individuals and 229 different companies or manufacturers. Although only 1,174 had activity to report, there are over 5,500 drug representatives registered as active in Nevada. So compensation was aggregated, all the information reported to us. Nevada healthcare providers and staff collectively received $3.4 million in compensation. The average compensation was about $21.12. And Jessica, this is table 7. This shows that most interactions involve small value compensation transactions. Compensation values were categorized into 2 compensation types, food or other. Most of the compensation was meal related at over 90%. And the average compensation for a meal was $19.42. Since last year, there was a significant increase in compensation events, a decrease in the total number of manufacturers, and an increase in the total dollars spent on these events, as I just described. Table 8 breaks down compensation by recipient type. Because meals are allowed to be reported in aggregate, many chose to report this way. This limits the detail of the information provided in table 8, as many fell into the office staff category, but they may also fit into another category. And there is a description in our report of, what does office staff describe and what is a other non-healthcare provider, et cetera. In addition, some activity was reported to us that was not specific to a Nevada representative. This included 3,600 more events. Nearly 100% were sampling events, although a few were meals, and a few cases of educational materials provided. This activity is not included in charts and figures that represented activity specific to Nevada registered representatives. So if you look at the samples that were provided by Nevada representatives, we've broken them down by the targeted health condition. And I think each year we've seen that it was typically dominated by diabetes, and it was this last year as well at 27%, followed by lung health at 12%. And again, in our appendix, there is a breakdown of what those categories include. I mentioned nonprofits report, but I think we only got one report this year because they are typically just publishing it on their own website. Wholesalers did start reporting this year. I don't think we got too much of value. We were looking at rebates that they may have received. We only received 3 reports from wholesalers, and 2 of them just did not have any negotiated rebates. One responded in percentage rather than dollars as requested. It's difficult for us to see who is required to report as a wholesaler because they're responding only to what's on our lists, and we don't know, we would have no way to know which wholesaler handled Nevada, the specific drugs on the Nevada lists. It's actually the same situation we're in with PBMs. While it's very obvious to us with manufacturers because we can see who made the drug, it's not obvious for PBMs or wholesalers. So that completes my review of our data, which would bring us to public comment again. So Jessica, I'm going to ask you to look for anybody that would like to speak, please.
Is there anybody who would like to make public comment?
Nope.
You can unmute yourself.
Okay, if we don't have anybody, then I think that is all I have, and I think that we will adjourn. Thank you.